Hello. Thanks for joining our Precision Medication Center of Colorado short patient scenario regarding optimizing cardiology medications using pharmacogenomics. Cardiology is an extensive area of study with multiple curated guidelines and annotations for various medications such as Plavix, warfarin, and simvastatin, where and when PGx results are available. Let's introduce the patient scenario to focus on optimizing three major classes in the field of cardiology using pharmacogenomics. Our patient is a 76-year-old male who is scheduled to go to the cath lab for a PCI, and the provider would like to know if Plavix is the right choice for this patient. To assess this, a preemptive pharmacogenomic analysis is done. Additionally, the patient has been complaining about muscle pain, and the provider would like to know if the statin is the cause of said pain. This is another question that could potentially be answered via the pharmacogenomic analysis. As you can see, the patient is a poor metabolizer for CYP2C19, which is responsible for metabolism of Plavix. Plavix is a prodrug and requires this metabolic pathway to be active and effective in the body, so if this patient is a poor metabolizer, per CPIC guidelines the recommendation is to use an alternative antiplatelet agent such as prasugrel. For simvastatin, it goes through this metabolic pathway as well, for which the patient has lower functionality. This puts the patient at higher risk for myopathy. Since the patient is already complaining about muscle pain, then our recommendation when we wrote our medication action plan to the provider was to change to pravastatin, which is a non-cytochrome P450 statin. Additionally, changing to pravastatin removes the interaction that simvastatin has with amlodipine. Now, how do we go about optimizing the warfarin? The patient is going to be needing mechanical mitral valve replacement and ongoing warfarin therapy for said indication. PGx results can give us guidance on how to initially dose warfarin. As you see here, this is the genotype of the patient, and if we put this to use via the package insert connecting the genotype with the appropriate other genotype, we can see that the initial dosing for the patient would be about 3 to 4 milligrams and adjusting from there as normal based on the patient's INR. If the patient had any of these other variations, then we would have recommended higher or lower doses accordingly. We hope this patient case was helpful to you. At Precision Medication Center of Colorado, we value our collaboration with providers and their referrals to us. If interested, feel free to view the other patient scenarios. Thank you.